Dr. Rajpal, we can start now. We are live. So Dr. Mistry will be joining shortly. So
Okay. Requesting all to switch on the videos. I'll be starting the introduction session now. So Swapnil, are we live?
yes, sir, we are live. We can start.
Yeah, okay. Welcome everyone to this lovely panel. I'll be introducing the panelists. The overall objective of this particular panel is to understand the healthcare capacity challenges in this COVID times, and we will have diverse range of specialists and doctors, including a person representing a pharmaceutical industry, to discuss how the infrastructure capacity was challenged in the COVID times and what they did about it, whether it was for their individual specialty or protocols or or supply chain delivery, etc., for the pharmaceutical products. So let's introduce each and everyone. Beginning with me, I'm Dr. Akash Rajpal. I'm the Executive Vice President at Medica Bazaar. Medica Bazaar is India's largest B2B medical supplies company, where we help thousands of hospitals to reduce their medical supplies costs. We help them save up to 30% of their procurement costs to on a regular basis. And the first panelist, which I'd like to introduce, is Dr. Naresh Hasija. He's the Associate Vice President, Public Health Business, Mylan Pharmaceuticals Private Limited. Dr. Viral Patrawala, he's consultant gastroenterologist at Dr. L.H. Hiranandani Hospital. Dr. Abdul Ansari, he's the Director Critical Care Services at Nanavati Super Speciality Hospital. Dr. Anup Warrior, Senior Consultant Infectious Diseases and Infection Control at Aster Hospitals. Dr. Aisha Sunawala, Consultant Infectious Diseases at PD Hinduja Hospital. Dr. Swapnil Mehta, Consultant Pulmonology at Dr. L.H. Hiranandani Hospital, and Dr. Rajesh Mistry, Director of Oncology, Kokilaben Dhirubhai Ambani Hospital. Welcome everyone to this panel, and thank you for accepting our invite to share your experiences with us. My first question of the session today is to Dr. Anil De Cruz, who's the Director of Oncology at Apollo Hospitals, Navi Mumbai. Congratulations, first of all, to you, sir. You are the first Indian to be elected as a president of Union of International Cancer Control, UICC Geneva. We would like to know from you how that matters and how it helps India manage cancer in COVID times and times to come. Please, sir.
Akash, am I audible?
Yes, you are.
Okay. So thank you very much for that kind introduction, and it's a pleasure to be part of this lovely panel. It's very topical and very timely. So the first thing is, uh, I am a practicing oncologist, but I'm also part of the Union for International Cancer Control. Now, quickly, the Union for International Cancer Control is the largest NGO cancer control body globally, started in 1933. It's situated in Geneva. You become a member not as an individual, but your organization becomes a member. So we have close to 1,200 members across 172 countries, and we have 58 partners. And these partners are various agencies, like, say, the WHO, the UN, the IARC, which is the International Agency for Research in Cancer, that does all the global cancer registry. So it's a very strong and high powered body. Now, the three major buckets or the three major areas of work of the UICC are advocacy. And to give you an example, say we want to decrease tobacco consumption, we are now taken up the e-cigarette menace, or we want to wipe off cervical cancer from the globe. So doing universal vaccination, supporting the WHO. So that's the advocacy bucket. Then we have what is known as capacity building, where we help members as well as countries to do various types of programs to help them in cancer treatment, delivery, funding, various kind of things. So there are various grants, there are master courses, and that's all in capacity building, getting people, their fellowship grants that many of us as clinicians have availed of to go abroad, train and come back. And the third is convening. We convene some of the very high-powered meeting, including participating at the UN Health Assembly, the Davos meeting, which is the Economic Trade Forum. So that, in brief, is what the UICC is about. So basically, the Union International for Cancer Control unites and supports the cancer community to reduce the global burden of cancer, to promote equity in cancer care, and to ensure that cancer control continues to be a priority in the World Health and Development agenda. Now, how does this affect COVID and how does it affect India? COVID has come here. It has shaken the way we deal with cancers. People are scared to come into hospitals. Doctors have modified their treatment protocols. Essential drugs are not available because supply chains have been affected. Funding has become a problem. And various organizations are shuddering with the financial impact of COVID, in addition to the treatment problems that it causes. Now, we at the UICC are putting together a strategic plan to help organization, institutions, patients across the globe in these troubled times of COVID. So, how will it impact in India? We have various members here in India, and many of them will be part of these deliberations. And whatever we do at the global level, learning from each other, will percolate to these various institutions of ours, who will then disseminate this knowledge within their ecosystem, and slowly it will go abroad. I mean, to other institutions as well. I also wanted to say that the UICC not only supports members, best practices will be shared with everybody across the globe. So basically, it's bringing the best brains together, bringing the best financial and healthcare brains together, and putting together a strategic plan on how we would overcome the crisis caused by COVID. I'll stop here because I don't want it to be a monologue. I'll turn it back to Akash, and then during the conversation, or even now, if there are any specific questions, I'll be happy to take them.
Thank you so much, sir, and congratulations again. I will direct this question and break a little seriousness by directing this question to Dr. Abdul Ansari. He's the Director Critical Care Services at Nanavati Super Speciality Hospital. Everybody knows Dr. Ansari to be a celebrity of sorts in this COVID times. He has taken care of the biggest celebrities during these COVID times recently. So, Dr. Ansari, welcome. How is it like managing celebrities, sir? It for many hospitals, I know it is a protocol in itself how to handle VIPs and all. So, what is your take on that challenges there, and what has been your experience? You can share a little bit.
Thank you, Akash. But I hope that doesn't end as my only introduction of managing celebrities. But thanks for the very kind introduction, as well as thank you CII for getting this very nice meeting amongst all the people.
We lost him. Did we lose him?
The question that you asked would actually be broken down in two parts. Am I audible, Dr. Akash? Yeah. So the question can be, divided in two parts. What can you do to make your COVID care much more open to all the strata of people, including the general public, as well as somebody who will need a little more attention, or what you call as a VIP care or a celebrity care. But I would rather, say that it all depends upon how well have you planned your infrastructure to begin with. So the biggest problem is now you don't have those same, comforts of having larger ICUs or single room ICUs that you would want for those celebrities, as well as those areas where they can have more space and probably better nursing care, and you don't have the best digital solutions to take care of them. So I would rather say that it was a moment for us to keep on asking us how can we, kind of review our care process for a special population group who would want more attention, who would want more access to the family and more access to the doctors without them physically reaching over there. Looking at that, I think the most important three things that we need to look for in COVID times is having good isolation facility, and not just isolation, but good air handling quality. Number two, a good digital solution platform where you would be able to look at your patients more, on a lively basis, interact with them to and fro, and get the family and communication. Importantly, you need to look at your protocols and guidelines for treatment. You may have to keep on looking at your protocols of care, which are completely updated because of the information blast that has been coming around. A lot of people would be asking you questions about the changing paradigm of treatment. So I think with that I'll sum it up that taking care of a VIP in COVID times, though is a pain, but I think it can be easily managed if you have basic infrastructure laid down well, and you provide a special attention or a special area for, kind of isolating them without isolating them medically and from the nursing point of view. I hope that answers some.
Yes, thank you, Dr. Ansari. So basically, what I understand is, yes, we have to keep in mind every strata of the population, but we always discuss that, and every doctor and HOD is kind enough to explain how that is done. But we can't also miss out on the fact that yes, we have some important, patients. Sometime it could be important to the nation also overall. It could be prime minister, it could be a superstar, it could be anyone. But yes, they have their different attention seeking things, etc. And what you rightly said is, for any kind of strata, I think what is more important is that you have to keep your knowledge and queries to the expected questions always ready, because there will be these relatives and patients who will keep on asking you things, and you have to be always up to date on what you have to reply to them. And maybe in this circumstance you should also have some kind of a holding area or some kind of a response area, where it doesn't crowd or create infection risk due to intermingling. Yes, I understand. Thank you so much. I'll come back to you again. Let me now direct my question to an industry professional, Mr. Naresh Hasija from Mylan Associate. He's the Vice President at Public Health Business of Mylan Pharmaceuticals. Welcome, Mr. Naresh. It was very right on CII's part to bring in the viewpoint of somebody who's not a doctor, but also supporting the doctors and the hospital with whatever resources it is required. So, what has been the Mylan strategy? My first question to you is, which has impacted lives during this pandemic time, and if you can talk more about how the tuberculosis service delivery, which was badly impacted, was tackled by you. So, if you can just answer these, and over to you.
Thank you, Akash. And I was just listening Dr. Crow's view about disruption in supplies. I think this was quite evident during the lockdown time. There, I think I would say that we as Mylan, are you able to hear me clearly? So there, I think we played a crucial role, and say that our integrated approach around digital supply chain. First time we saw this was the need of digital supply chain, and it was done so well, so flawless. We made sure none of our chronic patients who are on treatment they go out of their stock. Our key priority. So present patients, how they continue the treatment, how do we really take care of all our hospitals as well as pharmacies where we are supplying directly as well as through our distribution network. We made sure all this is available. And I think we took a lot of passes. We worked with government so well. Our factories were on during those times, as well as we were making sure uh, government, which is our biggest buyer, does not go out of stock. So the kind of planning we did with them. So we are country's largest antiretroviral suppliers to Indian government. So we made sure our supplies are on time. And an incident, I'll say that viral hepatitis drugs were due to government during this lockdown. I think they were amazed to see our efforts where, like, before time we delivered those medicines to them. Coming to tuberculosis, I think you have asked a question. Detection globally has gone down to maybe the tune of 25%. I will say that with regard to medicines, we were lucky. We were importing those medicines from our partner. We could import before lockdown and after lockdown. So there was no disruption in TB medicines here in India. But yes, our access initiatives, the CSR initiatives, which we were implementing at ground, were little affected. And now we are hopeful. I think very soon we should be starting those initiatives again. Over to you, Akash.
Yeah, thank you, Naresh. I will come back to you again in a while. I have few more questions for you, but now I'll connect the dots and I will talk to Dr. Swapnil Mehta. Welcome, Dr. Swapnil Mehta. He is the consultant pulmonologist at Dr. L.H. Hiranandani Hospital. Dr. Mehta, if you can just share your thoughts on how COVID has impacted the life of tuberculosis patients, and if you can take a cue from what Naresh mentioned about the challenges on tuberculosis, which he mentioned, what do you have to say about that?
Yes. Basically, if we see the detection of tuberculosis has gone down because of the lockdown, the people were not coming out. Even if they have some symptoms, uh, I think there is some, yeah, some disturbances there.
So it's okay, we can hear you, no problems. Go ahead.
Okay. So the patients were not coming out because of lockdown. There was a fear factor of catching the COVID infection among the in the general. It is still there. So initially, the notification of the tuberculosis cases has gone down. What we were seeing on a monthly basis, that in a initial few months of the April, May, it went down to zero, and gradually after, say, in the from June onwards, the patients started coming up, and basically that has also resulted into the patients presenting with a disseminated disease, I would say. The organs, and was not limited to, say, pulmonary part, or not limited to Pott's spine, if we talk about. And if I add it to further, the vaccination has also gone down in these times. So with the reduction in the BCG vaccination, we do expect that there can be a surge of patients. In one of the reports I was reading, like, they were saying almost there was around 60 to 70% in the vaccination in initial few months of the lockdown in the country. So that also impacted and the impact will be seen over a period of time. Like, it is not going to come right because tuberculosis is a chronic disease, and it slowly manifests in any of the patients. Secondly, the other important aspect is the tuberculosis pandemic, sorry, epidemic, I would say. And if we see it in context of the COVID-19, I would call it as a syndemic, the two diseases which are the deadliest one, and whichever uh, use respiratory case burden as well as the mortality. So both of these disease needs to be tackled in an appropriate manner. There has to be a extension of universal health coverage for most of the patients, the vaccination drive has to be stepped up, and uh, 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 we need to have been more aggressive on the research front. Like we have delaminide, as Mr. Naresh has highlighted, and we are using bedaquiline also for our patients. But we need to have a more further research has to be done in this field of tuberculosis to tackle the multi-drug resistant infections. And if I talk about Mumbai, we have a very high incidence of MDR tuberculosis, highest in the country. In fact, I would say. So that also has to be tackled in a appropriate manner. These are the few challenges which we should address here. I can't hear you. Hello.
Yeah, so thank you for your insight, Dr. Mehta. Thank you for your insight. I'm actually very taken aback to know that vaccination has actually, BCG vaccination has gone down to almost 70%. Maybe we'll discuss this in the second round to understand the impact, long-term impact of that. Maybe other people can also share their thoughts on that. That's pretty concerning. My next question is to Dr. Aisha Sunawala. Welcome, doctor. She's the infectious diseases at the P. Hinduja Hospital, and she has. I was discussing with her on certain aspects, and what really me was the secondary infections. So, welcome, Dr. Aisha. If you can tell me more about that, and and how did the infectious disease physician actually stepped in, especially at the Hinduja Hospital? You being an infectious diseases specialist, can you talk more about it?
Okay, so we understand now, 6 months into this pandemic, that secondary infections really have a tremendous impact on our sickest patients in the ICU. And although the intensivists and the pulmonologists have been sort of challenged and managing all other aspects of COVID in the ICU, and the ICU is where I'm going to stress, because that is really where we're sort of struggling with secondary infections. I think the other colleagues on this panel will agree with me there. But we've seen that as newer paradigms of treatment come in and patients survive longer, they have long-standing indwelling devices, lines, they're ventilated for longer periods of time. Um, so many of them are our oncology patients with other immunosuppressive conditions, other comorbidities that sort of make them susceptible to a host of opportunistic and other, infections that we commonly see and uncommonly see in the ICU as well. And all this actually eventually leads to sepsis and poorer outcomes. The first thing that we have to accept is that our COVID ICUs are different from our non-COVID ICUs. And although I think most hospitals have done a remarkable job in facilitating infrastructure in terms of practically, especially I can speak at Hinduja, that we've set up an entire new building and an entire new ICU facility for our patients. Yet there are always limitations to what can be achieved in such a short time. The infrastructure is not ideal. There is problem with staffing. There's problem with newer staff, untrained staff. We have to understand that for the first time as health caregivers, there is a greater concentration on personal safety, which we have emphasized on, but at the same time, it takes its toll on infection control, because the entire focus of attention is on protecting the staff, on each staff protecting themselves, making sure that they don't contaminate themselves. And very often, this actually sort of impacts to an extent patient care and infection control. We have to understand the discomfort, the challenges of working in hazmat suits, in PPE suits, the problems with doing what we normally would do for these patients, providing intensive physiotherapy, mobilizing them, repeatedly investigating them, transporting them to CT scan and other imaging places. So clearly, these ICUs, although they're doing a fantastic job under the circumstances, all have their own limitations and drawbacks. And that's something that we have sort of come to understand and are, working to overcome constantly. Now, that's where I think, so to give you a little background, at Hinduja, we started with having two entirely separate units. The ICU worked independent of the wards as a closed unit for COVID, all right? Where I actually stepped in was more recently, when we felt, gravely felt the impact of our secondary infections. And I think where you need to start is with an excellent infection control team, a good lab that looks at an antibiogram that is focused to the COVID ICU. And you'll realize, as we did, that perhaps organisms that you're seeing there, the epidemiology, the flora that you're seeing in your COVID ICUs is different from the rest of your hospital and different from, regional antibiogram. So we actually found organisms like Acinetobacter were, predominant in our COVID ICU, which we had never had a problem with for years in our non-COVID areas. And it's this antibiogram that actually reflects, so throws light on the gaps, the areas that require working on, the areas that are actually deficient. For example, nursing to patient ratio, hand hygiene, simple things like that. Hand hygiene can never be the same as glove hygiene. All right. And these are things that sort of require repeated looking into, changing of protocols, amending them, retraining staff, continuously auditing and serving. It's very difficult to tell an intensivist or a pulmonologist not to use empiric antibiotics on these patients. They're hemodynamically unstable, they're sick, their lungs are completely, fired. And stewardship and all seem ridiculous. Terms like stewardship really seem ridiculous under the given circumstances. But at the same time, I would emphasize on continuously surveying and auditing the infections that you're seeing and the impact that they're having on the mortality rate of the patients. And just by virtue of doing this, we've found a lot of areas that we could improvise on, that we could work on, and that we could rectify. So I'm going to stop over there.
So great, thank you. I think the next question will be in a logical flow. Will be to Dr. Anup Warrior. Welcome, sir. He is the senior consultant infectious disease and infection control at the Aster Hospitals. Welcome to the panel, sir. Would you like to add anything on this? And if you think there is certain experiences you would like to share, thank you.
Good afternoon. So, taking on from where Dr. Ayesha left regarding secondary infections, I think there has been a significant contribution of the therapeutic options which we have been using for COVID ARDS and COVID sepsis, which we are not using for our regular patients. There has been a widespread use of steroids, and even though the recommended doses have been on the lower side, but we have seen actually in different clinical scenarios, people use wide variety of doses and for longer duration than which has been actually sort of established in the literature or the RCTs. So high steroid doses, prolonged duration, again, sort of predisposes them to secondary infections. Widespread use of immunomodulators, primarily tocilizumab, also resulted in a lot of secondary infections. So I think the therapeutic protocols also played a reasonably important role in having higher secondary infections in this group. Other than that, looking at the infrastructure challenges from the infection control perspective, which has been one of the key responsibilities and difficulties which we faced from personally from my side. So even though we have had this airborne infection called tuberculosis since time immemorial, for some reason, none of the hospitals have ever planned for airborne infection control at all. This includes starting from the basic the TB control management in the government itself. They have guidelines on triaging for the cough and the fever at the outpatient, and then separate admission zones. But however, all this came into play and it took off only after the COVID made its pandemic and made its seriousness known. So the whole hospital has to be now reimagined into 3 zones. We had to have a triaging zone, which was both for your outpatients and for your emergency department when patients come in, where there would be a clinical triaging, radiological triaging, and an RT-PCR or an antigen-based triaging or a lab-based triaging. After this, then we had to have two zones within the hospital. You had to have a COVID confirmed patient zone, and you had to have a COVID negative zone. Now, this is for some of the hospitals, including mine, some of our facilities, it was reasonably okay where we had floor-wise air handling units. But in hospitals where the air handling units are not of that category, or they have other kinds of air handling units, it becomes very difficult, because it's not just the physical demarcation which is required. You need to also understand that the shared air is a risk when especially the air exchanges or ventilation is poor. So air handling units and demarcating the zones based on the distribution of air and ventilation was one of the aspects which we took care. However, there are certain areas in the outpatient procedures like dental OPs for instance, which this is a high risk aerosol generating procedure being done there. And we have never planned to have a high air exchange rates like the operating rooms or other procedure areas like a GI endoscopy or a bronchoscopy room in our dental OP. So these had to be enhanced with in-room air handlers where which we can put on or add on to the rooms to increase their filtration and increase their air exchanges per hour. So this was an infrastructure challenge which could be met with some addition of machinery. Lab was another area. Ours is a new hospital in Cochin, just about 5 years old now. And our focus and investment in molecular technology and molecular lab was not up to the requirement when it came to this COVID pandemic. And even in a large or well-established hospitals, the space allocated for molecular labs is actually not up to the mark, or which couldn't meet this kind of requirement. The amount of testing required, the biosafety level requirement. So this was again another infrastructure challenges which we faced. Sampling, because we couldn't do the sampling in general areas, outpatient sampling. So we need to have separately ventilated good or the external kiosks which you could take this patient up to the sample. So in a nutshell, we had to reimagine the hospital workflows. We had to reimagine the hospital infrastructure, physical demarcation, air handling units so that air separation is adequate. We had to add on facilities like outpatient testing kiosk, enhance the capabilities and the space requirements of our molecular lab. All this put together was the first 2 to 3 months was pretty hard on the infrastructure that way.
Great, amazing insights. What you spoke about, we never actually made a serious note about airborne infections and how COVID has brought that to a highlight. It's something which we will discuss more in the session in the next round. Thank you so much for your insight. My last question would be to Dr. Rajesh Mistry, Director Oncology at Kokilaben Dhirubhai Ambani Hospital. But before that, I'll be speaking to Dr. Viral Patrawala, who's consultant gastroenterologist at Dr. LH Hiranandani Hospital. But before I go to Dr. Viral Patrawala, I'll just tell Dr. Rajesh Mistry, as he joined in a little later, that I would leave that last question to you, and the question which I'm going to ask you is the impact of COVID on cancer. So before I come back to you on this, welcome Dr. Viral Patrawala. We have had discussions before this panel, and I would like to understand what has been the effect of this pandemic on your practice of gastroenterology.
Yeah, thank you, Akash. And the effect of COVID pandemic on the practice has been a big roller coaster. Initially, when the lockdown was announced, then it was a sort of freeze. Everybody was staying at home, and there was not much work in the hospital. But slowly, the entire hospital started getting flooded with COVID, and there were no beds left to do any other work other than managing COVID patients. So it was a very unfortunate situation. For example, I had one patient who was a long-standing patient of cirrhosis and had come with hepatic encephalopathy, and we had a very tough time finding a bed for the patient in the ICU because all the ICUs were taken over by COVID patients. They were full of COVID patients, and then how to manage these non-COVID patients who have now developed significant problems. Somehow or the other, those were very dark days where every day we would fear how to manage all our patients were following up for 5 years and 10 years, and now they are getting into complications, and now we are finding it difficult to provide them help when they need it most. But luckily those days have also passed, and slowly over a period of time, as healthcare and as all the other beds were opened up, we could at least manage the emergency patients well. The problem still remains was that now patients were very worried to follow up in the hospital. So patients with chronic diseases who require regular follow-up unfortunately missed a lot of follow-ups, and they landed up directly with complications. There were other patients also who are running around for quite a few months now with undiagnosed problems. Like a few patients were there who had ulcerative colitis, but they were bleeding, but there was nobody who was testing them to do a colonoscopy or a sigmoidoscopy to diagnose ulcerative colitis. So that was also a big issue. Slowly over a period of time, now I see that things are turning to normal as patients and doctors both develop some faith in all the safeguards which have been put in place, so that the doctors do not get the infection, and the patients also have the confidence that by going to the hospital, they are not going to a hotbed of infection. So slowly, I think that things are falling in place, and let us see how it turns out further.
So what has changed in your endoscopy practice?
In endoscopy practice, the whole thing has changed quite a lot, because endoscopy, the West came out with reports that it is a very high place where you can transmit COVID to the staff or even to the patient. So everybody started doing COVID test prior to endoscopy the world over. But the problem with that is that 30% of them may be false negative also. And initially, in the initial stage, lot of staff, even in the city of Mumbai, lot of staff and gastroenterologists turned COVID positive. And then, as we have a small amount of staff, it was very difficult to carry out the endoscopy practices in a lot of hospitals. So, but over a period of time, we have realized how to keep the patient safe, how to keep ourselves safe. A simple example I'll tell you is that now we give the patients betadine gargles before doing an endoscopy, because the aerosol generation is high. So that helps in preventing, at least for 1 to 2 hours, that the patients from generating COVID aerosols. We are doing most of the patients under sedation. And now a lot of standalone endoscopy centers have shut down. So as a result of which, slowly over a period of time, I see a lot of work coming to the hospitals, and hospitals getting flooded with endoscopy work. So this will change quite drastically over a period of the next few months.
Thank you, Dr. Patrawala. I'll come back to you again in a while. My last question for this round is to Dr. Rajesh Mistry. He is Director of Oncology at Kokilaben Dhirubhai Ambani Hospital. Welcome, sir. My question to you is, how has COVID impacted cancer care in this country? Would love to hear your thoughts on this.
You have to unmute yourself.
Dr. Mistry, can you hear me?
But I have to unmute myself. Okay.
We can hear you.
Welcome, Dr. Mistry.
Yeah, can you hear me?
Yes, we can
Yeah,
hear you
thank
now.
you. Thank you
Yeah.
for the invitation to participate in this wonderful discussion on COVID and how it has impacted the medical treatment. And I will be commenting on the oncology aspect of the
Yes.
yeah.
Yes.
So it has affected all three modalities of treatment, that is surgery, radiation therapy, and chemotherapy for patients. Like somebody said before me, in the initial few weeks after the pandemic, there was a lot of confusion. We didn't have set protocols as to how to go about, and therefore there was the slowing down of work. But fortunately, our hospital, we never closed down, and we continued to do our routine work. When it comes to oncology, oncology is surgical part. Though the oncological surgeries cannot be classified as emergency, one cannot keep postponing or deferring the surgery for a very long time because the disease will keep progressing. So the policy that we adopted was that all patients who come and where surgery is indicated, we continue to do so. Of course, the numbers were very less because of the lockdown. Patients were not able to come. There was a lot of apprehension, for a patient to come to a hospital, because of the fear of getting infected and all that. But whatever patients did come, we continued surgery. And of course, we had set in protocols so as to minimize the spread of infection. So anesthesia part was taken care of by having a hood while intubating, minimizing the number of personnel in the operation theater, wearing N95 and other PPI things which are required for protection. So while we continued with the operations, the number of operations had significantly reduced. But even people outside started realizing this COVID is not going to end anywhere soon, and cancer being cancer, they do require treatment. So then of course the workflow started increasing, so we had to modify, and all patients naturally who required admission, who required surgery, underwent screening for COVID RT-PCR test. The other part which I would like to highlight, and the observation that we had made, we did about 450, 60 patients underwent surgery for cancer from March to July. And when we audited, we found that, while patients were negative before we started surgery, some of them did become positive. In fact, about 3 to 4 patients did become positive in the post-operative period. So that is something that we have to be aware of. That is something that we need to be take care of. Now, this could be false negative COVID test pre-operative, or it could be the pre-clinical phase while the patient was, being investigated for COVID testing, or it could be that during the treatment or during the stay in the hospital after surgery, they got infected. So these are things that we have to keep in mind as a surgeon. When it comes to medical oncology, chemotherapy, there was a apprehension, just like doing surgery, as to whether we should give chemotherapies. There was the early part, patients started receiving weekly chemotherapy, small doses instead of the standard 3 weekly treatment. So some modifications were made, but with time now we are back to the original protocols because it impacts the overall outcome in patients with cancer. So with due care, where again all patients would get a COVID test done if they had to go in for a 3 or 4 day indoor chemotherapy. But those who were getting chemotherapy on outpatient basis, that is the daycare basis, they did not have COVID test again and again. And wherever possible, if the patients were from outstation, we encourage them to have the treatment chemotherapy locally with local medical oncologists. Coming to radiation therapy, again, the same thing. There was apprehension initially, so the numbers had gone down, but now, we are treating more and more patients. The care that we take is to space out the appointments for radiation therapy. Standard precautions are taken, and with that, the work is again picked up. So overall, I would say, to summarize, that in the initial 15, 20 days or 3 to 4 weeks, there was a lot of apprehension, a lot of fear. Patients were not coming. But now lately we find that, things are coming back to normal. And also the hospital, the doctors, everybody now knows what the precautions have to be. There are set protocols. So it's become easier to manage patients with cancer. So from the initial few weeks, now we are back to normal with set protocols for preventing spread of infection. Yeah.
Thank you so much. Interesting to note that negative patients prior to admission, which is a protocol, is they become positive. Maybe we'll discuss this in the next round as to the.
That is a reality which we have to live with.
Yes. So it's something which we should discuss in the next round. Thank you, Dr. Mistry. I'll come back to you in a short while. My next question, as the second round begins, is again to Mr. Naresh. He is from Mylan. I have an important question for you before you leave, Mr. Naresh. Is how has been your journey so far in India, and what do you think the key public health priorities at this juncture should be for India? Please share your comments.
So basically, we are very well known in antiretrovirals. So we are the largest supplier of antiretrovirals every second pill of the world is made by directly, indirectly with Mylan. So apart from this, in India, we are doing a lot of access initiatives around HIV. The second forte where we are working and across the world, we are providing accesses our oncology portfolio. So the biosimilars what we have, which we have partnered here in India and we are taking to rest of the world along with India. So we are doing a good job in that space. Second is so coming to, as doctor said, about viral hepatitis, that is also one of the foods we have, and we have partnered with central government here in India, and we are the sole supplier of viral hepatitis treatment across India. So, as Dr. Samuel was talking about tuberculosis, we could identify the problems around tuberculosis. We could see that last 30, 40 years, not much research has gone in this space, and employer TB is becoming a big issue. So, in that space, we started working and we partnered with a Japanese company called Otsuka, and we brought after 40 years of research, we brought a molecule here, MDR TB, and Stilamnide is available here in India now. And we are doing a lot of initiatives with Central TB Board. We are working very closely with the central government so that access can reach at the root, and we can identify more and more of multi-drug resistant cases. And then we see around tuberculosis, we see that pill burden is one of the biggest problem as well as the duration of treatment. So now we have taken up these two goals, and we are working very closely with all the experts, starting from WHO Geneva, Central TB Board, and I think we're very hopeful we will able to solve these two problems also. Our keen goal as an organization is to really reduce pill burden in tuberculosis along with the duration of treatment if we can shorten. So these two areas we are experimenting, and very soon we will have drugs coming in this space. And coming to COVID, which is like, I will say that from the month of February, all our machinery came together here in India when we saw that this is such a serious problem. Whole our supply chain, back-end, R&D, manufacturing, IP, regulatory, everybody came together in such a short period of time. We came up with remdesivir, and you can see that our remdesivir is providing access across the country. So our major focus was to provide this access to almost all the COVID hospitals, whether they are in private or public. And you can see that in last 60 days, we have partnered with all the 26 state governments, and we are the regular supplier to these state governments. Almost, I will say that we have impacted almost 1.5 lakh COVID patients, families. So with this, I will say that infectious disease is our strong forte. We really want to create a huge difference across India, and for this, I think we are partnering with both the sides. We are partnering with large companies if they have some nice molecules, as well as we are partnering with the users, the state governments, large corporate hospitals across India. Thank you, Akash.
Thank you so much for your insights, and thank you for coming and gracing this particular panel. I believe you have to leave early, but you can stay back. It will be nice so we can have your final thoughts in the end if it is possible. Thank you so much again. My next question is to Dr. Abdul Ansari, Director Critical Care Services at Nanavati Hospital. Sir, we had a great insight on managing different state of patients, especially the celebrities and challenges. I would like to know more about the infrastructure capacity building measures you had to undertake to mitigate overall in your hospital COVID related challenges. And what do you think your way forward is for intensive care as a whole for this country, in case other hospitals are listening to us right now and they would like to hear from you what important aspects they have to look into now going forward?
So, thank you, Dr. Akash. I think this is a very, very interesting and important question. What exactly did we go through in the past 7 months, I would say, so that we could take care of the surge capacity. I think the important thing to note is based upon the healthcare worker, the personnel, and the material and containment. We had to do certain changes for that. And the most important thing which I would like to highlight is that we had to take into account that all the healthcare workers who were coming for taking care of COVID-19 patients had to be specially taken care of, as Dr. Aisha also spoke, that this is the only condition in which the healthcare workers had to be specially prepared for taking care. And that was something which was unheard of before. Most of our healthcare workers were transportation, moving lodging, their infrastructure cost had to be taken care, training cost, oxygen, accommodation, and the most important, their rest areas. Most of our healthcare workers who would work for a good number of hours would also need to be given a rest, a cooling period. So our healthcare capacity actually increased to 50%. So if we had 40 staff in a particular geographical area, their total number actually reduced down to 20 effectively, because when they would work just 5 days or 7 days, they would need to be given an off so that they can come back on the full capacity. This was something which caused a major with our capability of handling more and more patients. Number two, when we come back to their transportation, they all were coming from areas where they could not stay close to the hospital. I think there is a lot of background noise. Uh, Apart from that, most of them also had their own challenges, because a few of them would not be fit enough to go and work because of their own medications. They would be, a few of them would be diabetic or hypertensive. So we needed to take a lot of untrained personnel also into those areas. There were a lot of problems with our training about the doffing, donning, and understanding that they would catch infection there themselves. And coming back to the second part about the hardware changes, we had to make areas for donning and doffing. Most of our equipments which were going inside could not be reused in other areas. The echo machines and other things could not be easily transported from one unit to another. And then there were special transportation measures which had to be taken inside the hospital. So when a person would go for a CT scan, we have to ensure that it would be done in only a period of time, where there was a COVID corridor created. They would go for any kind of an emergency procedure on slotted times. And apart from that, free movement of the consultants inside those areas was also not possible. So a lot of those changes had to be thought about. There were practically daily meetings with administration and the healthcare providers to really understand what could be the best way forward. And when we spoke about that was for hand sanitizers. And our management was working very close along with the medical administration and the caregivers. And we had to keep on reinventing ourselves every week to really keep up with the pace of information that is coming, and reviewing the treatment algorithms, incorporating, deleting the drugs that probably incorporating and deleting those processes that we were doing, which were probably not as beneficial. And then there were the special challenges about getting the right inventory of medications. So there was a point where there was tocilizumab in shortage, remdesivir came midway, and favipiravir also came much later, and after the recovery trial. So I think enough has been handling. This is for the first time where we were learning about the disease. I'm sorry for the disturbances in between. I hope I was audible.
Thank you so much. Amazing. I think CII should take an excerpt of this entire session and make this into a widespread publication. I think there were some amazing responses from people today. and CI has recommended that this should be published into an article. Maybe if editors are looking at into this, do stay back, Dr. Ansari, in case you have any last thoughts to this session when the session concludes, which will conclude pretty soon. My next question is to Dr. Aisha Sunawala. I would like to ask her one thing. The third case of COVID reported in Mumbai was admitted in Hinduja Hospital. Okay, this was in late March, if I remember that right. What was the initial impact and what has been the journey thereafter for you?
Right. So I must say that in the period when we first had our first few cases in Kerala, and after that there was a lull. It was during those few weeks that I must laud Hinduja for this, that the infection control department is something that really sort of stands out with our microbiologists and stuff. And it was right back then that we actually formed a task force and started sort of looking into how we could prepare for this. And just as Dr. Ansari said, we started holding daily meetings right from way back then to sort of determine how we would deal with the eventuality of having cases. And yet no amount of preparation could adequately prepare us for that first case that hit us much sooner than we thought it would. There were 2 cases at Kasturba, and we were the first private hospital with a case at that time from Dubai, when Dubai wasn't even considered country from where infections were sort of COVID was thought to have spread. And sort of overnight things transformed. What helped was that the dialogue had started, the discussions had started. We had already delegated tasks, designated responsibilities to different departments. And by different departments, I mean it would have been impossible without the complete sort of involvement of the entire functioning, every department of the hospital, right from the admin to the engineering, which, as Dr. Anup also pointed out, and Dr. Ansari also pointed out, that despite having all these infection control norms and protocols in place and all, there was very poor vision, very poor foresight into the need for airborne isolation. And the engineering actually worked marvels at putting up walls where there weren't walls, changing things to airborne isolation, negative pressures, air handling. And this all happened in a matter of hours and days, as we just spoke and planned and brought things out. And engineering, housekeeping, laundry, food services, HR handled the entire contact tracing of healthcare workers that came positive. Each department took responsibility for their healthcare workers who came positive, handled the surveillance and contact tracing and things like that. A new micro PCR biosafety level 2 lab came up within a matter of weeks. Of course, we had new wards and new ICUs being erected every sort of few days and weeks. And there was an ongoing infection control training that still continues today as we have new workforce coming into our sort of teams and joining us. And this is not just for workforce, this is workforce including physiotherapists, housekeeping staff, dietitians, nursing. So that the training and the constant sort of updating of information is immense. And then again, creating protocols. There had to be protocols created for everything, as Dr. Ansari pointed out, right from transport to triage to how you would expect somebody to take a history and diagnostics and everything. And most importantly, protocols for management in an evidence-free zone. Very difficult to put down a protocol for management in a time and in a zone when there really isn't any evidence for treatment in a particular way. And I think the one thing that we all decided on at Hinduja and we adhered to for the longest time until we had more data on remdesivir and steroids and things like that is that we offered largely supportive care. And the only time we deviated from this was when we were part of a drug trial for, So everything that was done away from protocol was done under the auspices of a drug trial. So that's pretty much how our journey has been, and it's ongoing, and it's an ongoing struggle and a challenge that we sort of deal with every day. And there are new challenges.
Thank you, Dr. Aisha. I'll come back to you for your concluding comments. Before that, I'll just go to Dr. Swapnil Mehta, who spoke in depth about the impact of COVID on the tuberculosis patient. I just want to ask him to add a little more. What he sees now, especially now, is there any difference in the new infrastructure or training requirements needed, especially in the care of tuberculosis patient or in the field of pulmonology as a whole? And how do you see the future course of pandemic affecting this particular field of yours? And after that, then I'll head to Dr. Anil De Cruz for his view. Dr. Swapnil.
Sorry. Yeah, actually my mic was off. So basically, if we see, there is a need of because these are all respiratory diseases. If we talk about tuberculosis, if we talk about COVID-19, and they spread by coughing, sneezing, that way. So for that, we have a HEPA filter set in my department in Hiranandani, and that does take care of air exchange. But with the rise in incidence of COVID-19, I do feel like there should be separate air exchangers for whole hospital in every department, because you don't know whom you are dealing with, who is a COVID positive, who is COVID negative, that way. Secondly, if we talk about procedures like pulmonary function tests, then all such procedures like PFT, bronchoscopy, they all involve dealing with the airways, and uh, uh, to prevent the spread of infection from one patient to other, we have prepared the checklist. We have trained our technician. Dr. Ansari also spoke about the untrained personals and transportation of staff and patients in the hospital. And similar to that, the similar measures have been taken in my hospital also. uh, we have prepared checklist in the PFT. We are screening the patients, all those patients who are coming from outside, who are not been referred by the consultants over here in the Hiranandani hospitals. All those patients have been screened by that particular checklist, and that way we are trying to prevent any undue case where we are performing a PFT for a COVID patient, and that leads to contamination of the instruments. Secondly, the infection control practices have been improved in the hospital for pulmonary function test, for bronchoscopy. Dr. Patrawala also pointed out about the endoscopy, that they are doing the COVID test for the patients, and similarly, we are also screening such patients, and are that way the bronchoscopic procedures have gone down over a period of time, because we are not doing it until and unless it is extremely necessary for the patient, and there is no other way to diagnose the patient or to take the sample.
Great. So I think the last round is just about to end, but before that, I would like to ask Dr. Anil De Cruz, in his opinion, what has been the impact of COVID on cancer? Though I asked this question earlier to another panelist, but I want your views also, and how COVID has really impacted the mortality rates among the cancer patients, and what do you think should the way forward now be as a new norm?
While I agree, am I heard, Akash? I'm heard.
Yes, you are audible.
Okay. So while I agree with everything that the panelists have said, I have a deja vu. Uh, Years back, when the HIV epidemic or the HIV infection came, surgeons would get scared to operate. We said patients are in the window period. We didn't know what would happen. And finally, we kind of came into a state of equilibrium. We now test for HIV and we operate all our patients just taking precautions. We were not sure whether we should have special kits at that time, the risk that the personnel would take. Similarly, in COVID, initially there was a lot of panic. It's a new disease. We've been learning. Think what happened in March and April. If a patient was positive, they would be packed off into a quarantine center, something like they had the syphilis of the old days or open tuberculosis and would infect everybody. 6 months later, if you're positive or even have mild symptoms, you just stay at home and you home quarantine yourself. You may or may not get treatment and we'll find an equilibrium. Till such time as the vaccine comes, we'll find a new normal. Whatever we do about airborne transmission, we have changes in the hospital, we create new ICUs, new circulatory systems. It's going to have an impact on cost. And these are going to have uh, equity issues where a lot of patients will not be able to avail or just jack up healthcare costs. Now, if you ask me, Dr. Mistry and team, he quoted really 4 months, which is sizable. At our hospital, work kind of dropped. We did a fair number of surgeries, but I would say the entire hospital would work at about 30%. We didn't know what's going to happen, but slowly, as I say, the incidence of cancer continues. It's not going anywhere. Not going anywhere. So patients have started coming back to seek treatment. But for every dark cloud, I see a silver lining. And we are going to learn a lot from COVID. We are going to learn to be prepared should we have another airborne infection. We'll be absolutely prepared and we won't run. In oncology, I feel we learn a lot of cost effective treatments. For example, radiotherapy fractionation is changing in a lot of conditions so that patients come less to the hospital and we give smaller fractionations of radiotherapy. Chemotherapy is becoming less intensive. And I don't mean to trivialize or to say it's going to be in everything, but in some conditions, yes, it's going to change. Our consultations will change and we'll do a lot by video consults. We don't need such a large footfall into hospital where patient pays a lot of money traveling across cities to see their consultant. Maybe they'll do their local investigations and do teleconsults. All this might translate into some sort of savings, and I see these savings may be channeled into cancer treatment or more importantly into prevention. Now, screening, which is so important for early detection, has stopped in most countries. And the majority of developed countries aim to have 80 to 85% of their patients in stage 1 and 2. Does this have an impact now that they're going to see patients in stage 3 and 4 on us? In stage 3 and 4, I don't think that's true. I just think there'll be new normal on how we do screening programs. Maybe they'll do it low and we will get our early diagnosis. So I see a change, and I'll only wind up by saying this is evolving. There's nothing sacrosanct now. There's nothing hard and fast. We've changed practices over 6 months. We'll continue to change over the next 6 months, and we'll find a new normal where we'll all be in a state of equilibrium.
Thank you, Dr.
Back
Anil
to
Cruz.
you.
Dr. Rajesh Mistry, would you like to add on what Dr. Anil Cruz left at?
So Dr. Mistry had some emergency, so he had just left. He'll be back.
Yeah, okay, no problems. We are at the final stages of winding up this session. The question now goes out to Mr. Naresh. Is he still around?
Akash, I'm there.
Hi, Naresh, do you have any last words continuing on that line of new normal? What do you think? And do you think the remdesivir supplies are pretty robust now? Can I count on you? Can I give you
Yes,
some
I think.
orders?
Yeah, perfect. I think this is a perfect question in this situation. So I think we judged it very well, and we worked with Director General of many states, and we could understand what kind of requirements we will have across the country. We work with DCGI to take one more plant approval. So we can assure you, we have enough stocks for remdesivir coming forward, and looks like remdesivir is a bridge up till vaccine comes in place.
Thanks, Naresh. Dr. Anup Warrior, what is your take on the new normal going forward, especially keeping in mind we are not only talking about this COVID situation, but going forward, what do you think the hospitals have to be careful about? What kind of setup they have to keep in mind while expanding or setting up new departments, etc.
So I think for any new hospital which is coming up, or like what Akash was saying, expanding into new facilities, couple of things is that we have to keep in mind the capacity which would be required to cater to airborne infections. Like I was mentioning in my earlier part, that though TB was around for a long time, we never had our hospitals in order to manage the sufficient airborne infections people in our facility. So a rough rule of thumb is that you will require, for a secondary care hospital, you will require about 10 to 15% of your operational beds to need to cater to airborne. And for a tertiary care, you will require as high as 30% of your operational beds, which would include a couple of your critical care units also, which can cater to the airborne infections. So this is important to get it right from the design stage itself. All of us now require, all of us are quite aware of the workflow changes which are required, and hence the design can be built around the workflows which all of us are familiar with the COVID pattern now. The other aspect is to focus on the ventilation. Now, there are certain areas, a couple of areas are well known to, as ICUs and operating room, where every design engineer knows that the ventilation is important and they put that in the design. But now we know that there are areas like ICUs and patient waiting areas where you'll have huge clusters developing if ventilation is not right. You have staff changing rooms where again, if the ventilation is not right, you'll have clusters happening in your nurses and your paramedical staff. So you'll have outpatient waiting rooms and OP areas where again, if ventilation is not right, there will be a lot of nosocomial transmission. So when we plan our new hospitals, we have to focus in these areas which are neglected earlier from the terms of risk and in terms of having air exchanges of more than 12. So this is again something which you have to think about. We can also think about low cost measures like natural ventilation, both in terms of while admitting patient and also for these waiting areas. Yeah, other than that, we need to also carefully look at investment in microbiology and molecular diagnostics, which is the core of diagnostics to come ahead. So a lot of impetus and importance to be given to molecular microbiology. Not easy to suddenly develop a molecular lab when you have a pandemic or when you need the screening facilities in-house. Lastly, the core design, whenever we think of it, the changed workflows in terms of triaging, especially the triaging requirements and the special pathways and transport requirements, etc., has to be kept in mind, because again, to create ad hoc gypsum based walls suddenly when you have an outbreak is not, that should not happen the next time. So we have to work around the workflows and build our infrastructure as such. And before we close off, just one point to take back again from where Dr. Ayesha had left. So we are still not coming to terms with whether fomite transmission is important or not. And a lot of our workflows and infrastructure investments are also considering this aspect. So as of now, the most of the evidence publications say that fomite transmission is not that important, while all our government policies, the state government and central government policies, they place a lot of impetus on fomite transmission, like what Ansari was mentioning about having separate paths for people and material to go in and go out. Is it really required? Should we invest in these paths and disinfection of these pathways if fomite transmission is not that important? The handling of biomedical waste and the deceased bodies, the dead bodies of people with COVID. Again, a lot of impetus on fomite transmission. So is all these required? the evidence has to come into forefront, and when we plan, we have to take this also into the consideration. That's all, actually.
Thank you so much. I will direct the concluding question of the session to Dr. Abdul Ansari just in a while. But before that, the second last question is to Dr. Viral Patrawala. So, what has changed in your hospital practice, in your field, and what do you think the new normal will be? Quickly, if you can share your thoughts, Dr. Patrawala.
Uh, Dr. DeCruz has said a lot of what I wanted to say. One thing which I am seeing is that video consultations will come up in a big way. I personally am not very comfortable with doing a video consultation for the first consult, but for follow up, it is a big boon to the patient. They can sit at home. You have already seen the patient. You know what few things you want to see in the patient, and it is really very convenient to the patient, saving a lot of time, money, and ease of follow up for the patient. The second thing which I am seeing in endoscopy practice is that what is going to happen in the near future is that more and more of the endoscopy suites are going to become that we will be doing all the procedures under sedation only. Earlier, we used to do quite a few diagnostic procedures under local anesthesia. That's going to go away with this, and it will become a very concentrated practice. So there will be a huge, big endoscopy centers with a lot of endoscopies attached to it, and that will be driving the future. And all the small standalone endoscopy centers will slowly wither away. These are the two big changes which I am seeing in my field. Thank you, Akash.
Everything under sedation. Wow, that's something interesting to talk about. Thank you all so much. The concluding question is to Dr. Ansari. Sir, what do you think the new normal has to be, especially keeping in mind intensive care?
So I think so. The new normal is to live with these kind of catastrophic developments and diseases. I think every hospital will need to have teams A and B, kind of always, or what we call as a contingency team planning, so that if you have a COVID kind of a situation or a similar kind of a disease which comes in, you need to have your intensive care or your other physician practices and surgical teams to be capable of looking onto both the aspects. As Dr. D. Cruz also mentioned that, a lot of chronic care suffered in the beginning. A lot of patients with chronic kidney disease suffered in the beginning as well. So I think it is very important that the hospital should very easily know that there are two phases of any problem. We developed what is called as a very early in the beginning. So we knew that our otherwise cardiac emergencies and regular kind of admissions could come into the green side, can be screened over there, and as a matter of fact taken into the regular kind of treatment protocols, while the sick ones who were known or were highly suspicious of COVID should go into a different segment and should stay isolated there, and gradual controlled release on the other side should happen. Our manpower, in fact, my critical care manpower, we distributed it into two teams. One team is self-sufficient, rotating inside the COVID area. The non-COVID work keeps on moving on. Number two, the most important thing was we had digital solutions this time. We needed to have on-call consultations, Zoom calls, WhatsApp calls. We, for the first time, had bedside teleconsultations with the family and communication pods where we could discuss with them. For the first time, the patients were allowed to have phones by their bedside. Now, that's something which is very, very different. And I think it's also tricky for us to think what will happen if a person who is in the ICU is kind of sending his own images to the outside world. And that's necessary, but also full reality. So I think that is also something which we all need to have some laid down, kind of protocols for communication. And last but not the least, good infrastructures, kind of preparations, like which would be the areas, just like the trial. You need to have kind of, certain surge capacity building where you have open areas, how you can stack up some beds there, how can you create easily increased number of not just critical care but high dependency unit beds also. So I think it'll need a lot of healthcare planning now, and we need to collate all the data from every specialty, right from the administration, the management, the clinical administration, the various aspects of clinicians, and then we need to come with white papers to understand how should we kind of tackle these problems in the future and how to emerge wiser. Thank you very much.
Amazing. Thank you, CII, for arranging this amazing panel. I think in the entire COVID season of webinars, multiple which I have attended, I think this was among the best. It was a personal learning for me also. And thank you, everyone, right from Dr. Rajesh Mistry, Dr. Swapnil Mehta, Dr. Aisha Sunawala, Dr. Anup Warrior, Dr. Abdul Ansari, Mr. Naresh Hasija, and Dr. Viral Patrawala, Swapnil Muke from the CII for coordinating this, Joy Chakrabarti for arranging this amazing line of events at CII. Thank you all so much, and thank you for inviting me to moderate this panel. I think the next way forward is going to be a new normal, which has to be defined from time to time to time to come. Thank you so much.
Thank you.
Thank you, Dr. Rajpal, and thank you all the panelists for joining us.
Thank you, everybody. Thank you.
Thank you.